I got another question ahead of this interview about what are the sacred cows in the industry that you see as probably at risk for changing over the next 3, 4, 5 years?
You know, I think in behavioral health, you know, one of the things that is, I'll say a cultural thing within behavioral health is.
Welcome to another Meeting of the Minds podcast. This is part of the series that we're doing at Behavioral Health Tech 2024. We're extremely thankful to have been out there podcasting, but there was somebody that we couldn't quite catch out there on the floor. There was a whole lot going on, and because we couldn't do it in Phoenix, we're here at Tech Town, Detroit, on Wayne State University, talking with Dr. Taft Parsons, who is the Chief Psychiatric Officer for CVS Health. So we're really, first of all, proud to be filming this in Detroit, in an innovation center within Detroit. There's a lot of personal meaning, as you see all these, like this is an innovation space where you're going to see people in the background that are innovating, leading. But we want to zoom in with you, Dr. Parsons, on a conversation that connects leadership and innovation to a personal background and personal story that drives the fuel behind it. Before we get into it, anything that you'd like the audience to come away from this conversation with?
All right. Now, since you did mention Detroit, I will have to say what up, though, to all my Detroiters that might tune in and listen to this podcast. You know, so I think as I think about and kind of thought about like what we'd be talking about, I wanted to make sure that people who are listening to this podcast get a sense of, you know, kind of where me working for a payer and kind of where payers kind of sit in that healthcare space. But, you know, I think, you know, when you're there working with folks, what you do find is a lot of people, and in particular, a lot of clinicians that are very passionate about the work that they do. And from the place where they sit within healthcare are really trying to get the folks that are members of those health plans the best health outcomes possible. And so it's a very different perspective that I think sometimes folks don't really understand. And so hopefully folks tuning in will get a sense of like, you know, what is it that health plans actually do as it relates to the health of populations and individuals that are members.
Like if we're looking at from 90,000 feet, we can look at tech and say things, and we can look at various industries and say things, but it's all about zooming in and understanding who is powering the right type of work. And hopefully, Taft, a big reason I wanted to have you here is that concept of leading by example.
Yeah. So
that leads me to a starting question is, can you talk about, like, you outlined a journey from just I'm a human being, then going into medical school, learning, going into psychiatry, and then moving into step by step into the role that you have today. Can you paint a picture for us and connect that personal story to why you're making impact today?
Yeah, I mean, you know, and I will say, I don't think that you have some people that I went to med school with people like, I wanted to be a doctor since I was like 5 years old. And I was not that guy. You know, I knew that I enjoyed science and math. I had passion for it in high school. When I got to college, I said, you know, I'm going to do something in science. So, you know, at that point, I did not like biology. So I said, let me get that out of the way first. And I had a fantastic professor, Dr. Clark, for G-Bio. And he just kind of ignited a passion in me for the life sciences. And so I decided to be a bio major at that point. And then, you know, still hadn't decided to go to med school. Got to my physiology class with Dr. Cook, who I will say probably had the biggest influence over my career path in life. He kind of taught us how those organ systems work together, and I thought that was the coolest thing ever. And I said, where can I get more of that? And it was going into medicine. So, you know, as a kid, originally from Milwaukee. I was lucky. I got into the magnet school track, the gifted and talented track, which was a lottery system at that point. So I'm 100% sure that there were a lot of other kids who were just as intelligent as me, who, by the way of their name, didn't get drawn out of that metaphorical hat, never got the same shot that I got, and ended up in, in less well-funded schools that didn't provide the same set of resources and opportunities that I got. I'm glad that I got it and took advantage of it. Went to what they call Golda Meir, and then Morris Middle School, and then Rufus King High School, which is an international baccalaureate high school. And, that entire time from third grade through graduating high school, it's geared towards talking about what are you going to do as an adult? How are you going to go to college? How are you going to be successful? Providing those really kind of passionate teachers that, kind of influence your life in ways that you don't understand until you become a middle-aged person and look back at it. I still remember Mr. Mitchell, my fourth grade teacher, who graded me really hard. I was getting like B's and C's in his class. And at parent-teacher conferences, he said, look, I'm not giving you A's, not because you're not good and you don't know the material, but because you're not working up to your potential. He was the first African-American teacher that I had, and he held me to a higher standard than other folks were holding me. And that helped. That was kind of like the kick in the butt that I needed to really kind of take school more seriously.
Can you, I know we have a whole story to tell, but can we zoom in on this and talk about how that made you feel in the moment of being held to that higher standard?
I think as a fourth grader, I felt like it was unfair. I was like, why is he, making it harder for me than for, my other classmates? But, I think him, already kind of being in that position as, and I don't know if he was middle-aged at that point, as a middle-aged Black man, looking at this kid that has potential and talent and saying, what does this child need to really kind of give him the push to live up to his potential? I think that, now I really appreciate that. At the time, I was like, I should be getting A's because I know this and I did well on the test. But, the manner in which somebody who can kind of read what a child needs and provide that for them in a structure that is, maybe not easy, but supportive and loving, is a different type of experience than I think a lot of kids get. And so I was somebody who kind of benefited from that, by divine intervention or by chance. Either one, I think that it gave me the opportunity to kind of, build on that over and over again to the place where I am today.
Yeah, there's a lot to be thankful for in that, and knowing that, he knew something different about the world than you did. And I'm implying that the difference is because of our skin color, because of various elements of the background, we ultimately do end up having to work harder.
Yeah, I think it was made famous by Olivia Pope in that show. What's the name? What's the name of that show?
God.
I'll remember it in a minute.
We'll flash it on the screen.
But her dad said, he did the whole kind of, you got to work twice as hard to get half as far. And I think that was the first time that a lot of folks outside of the African-American community had heard something like that. But this is kind of an accepted notion and a standard within our community that, we are not going to get the same benefit of the doubt that a lot of other folks get. And so we have to demonstrate excellence to a level that other folks don't have to demonstrate it. And I think Mr. Mitchell kind of being in that position, he didn't necessarily say it at that time, but that's what he was doing. He was saying, look, you may be performing as well as these other folks, but I'm gonna grade you harder because you need to step it up to the next level in order to be as successful as they are all going to be in life. And so he was the first African-American teacher that I had, and one of a very low number of male African-American teachers that I had. And I think, probably the next time that I had multiple black male teachers was in undergrad at Morehouse, which, I think was another kind of opportunity that came to me, somewhat unintentionally. I was a good student. I was an honor student. I had not at that point planned to go to an HBCU, and so now I have to give credit to John Singleton as a director, because I thought to myself, I was like, well, I should probably apply to one HBCU while I'm applying to colleges. Why did I pick Morehouse instead of Howard, instead of Tuskegee or any other HBCU? Well, it was because Boys in the Hood had come out. And at the end of Boys in the Hood, Trey went to Morehouse. And I remember that, and that was the only reason that I picked Morehouse as the HBCU that I applied to, as opposed to any of the other ones. And I will say that Morehouse changed my perspective on life. It changed the direction of my life. It has had everything to do with everything that I've become after that.
That leads me to a specific question then. How did Morehouse inspire you down this direction of psychiatry, as opposed to all the other specialties that you could have focused on? Like all this building into a point, why the focus on the mind?
So I'll say Morehouse got me to medicine. It didn't get me to psychiatry. And Dr. Cook that I mentioned, he was the one that kind of put together, how these things that before I had been looking at under like maybe a microscope, like cell biology. It's cool to look at cells under a microscope. Dr. J.K. Haynes would probably rail against me for not saying that was the coolest thing. But it was interesting, it was engaging, but more on kind of an intellectual, esoteric level. When Dr. Cook would then talk about, how do all these things operate together in organ systems, it became very tangible and real to me, and it turned it into something that I became passionate about as opposed to intellectually interested in.
So I loved the beginning of the answer when I asked about psychiatry, which was looking at the cells and systems and how they work together and everything like that, because you keep I guess the smallest level of abstraction is physics, when you're looking at all the way down to the atomic level, that these things coalesce, then cells coalesce, and then all of a sudden you get us. And then it's a question about how we relate to each other and work with each other and think. And I'm just curious about what the connection is the moment that you decided that you wanted to go into psychiatry as a field.
All right. So I became a psychiatrist on the day that I was told that I was not an emergency room physician. I was going through med school at the time when the show ER was out. So, tons of people wanted to be an ER doc. And so I thought I was either going to be an emergency room physician, and I had done research in an anesthesiology lab at the medical school. So I thought I might go into anesthesiology, had my whole fourth year schedule set up to do that. And I started my fourth year with 2 ER rotations. My mentor called me into his office. He was the chair of the department. And from his office door, you could see the emergency room. And so he points out and he goes, "You see that guy over there?" And there's some resident. He's running back and forth from trauma to trauma. He's sweating bullets. He's all over the place. He said, that guy's an emergency room doctor. He said, "Now you see this guy over here?" And he pointed out this other ER resident who was calmly walking with a clipboard from patient to patient, taking his time. And he said, "You're not that guy, you're that guy." And he said, "That guy is going to finish his ER residency, and he's going to go and work in a suburban urgent care center, and he's going to regret that he did emergency medicine." He said, you're that guy. You're good, but you don't have the passion for it. You need to figure out something else that you're more passionate about." And so at that point, I had to kind of reflect on other rotations that I had done. And I had done my psychiatry rotations in a locked unit county facility in Milwaukee. And it was 6 weeks of kind of the most severely mentally ill folks you could imagine. People that had chronic psychosis, people that were on forensic confinements, and every day, I was enthusiastic about like the stuff that I had seen that day. And so I changed course and made the decision to go into psychiatry at that point. My interviews for psychiatric programs were interesting because people would look at my transcripts and they'd be like, well, it looks like you're set up to go into ER or something else. Like, why are you going into psychiatry? And so, I had to tell that story over and over again. And, kind of coming into, I'm matched at Henry Ford here in Detroit, which is literally, a couple blocks away from this building. And on starting residency, I really grew to learn that I made the right choice. Particularly when I did my inpatient rotations. This is where you're taking care of the people who are in the biggest crises of their lives. They have the most severe illnesses. And I would go every day and think to myself, these are my people. And not so much, that intellectually I really enjoy these complex patients. I thought to myself, these are my people because I grew up around people that had illnesses like this. They reminded me of family members that I have. They reminded me of people that were in the neighborhood that I interacted with on a regular basis. And so to bring that mindset that these people remind me of people that I really care about, I think affects the way that I can interact with them in hopefully a very empathic manner, professional manner, and treat them, with the dignity that people, despite their illness, that they deserve.
So when I think about that relationship, and especially the way you painted the picture of him pointing to the man with the clipboard walking around, that
was a little bit of a narcissistic injury. It hurt my feelings to have somebody tell me that I shouldn't be doing the thing that I think I want to do, But sometimes you have to get that feedback and that criticism, and you have to take it and you have to accept that that's somebody who knows what they're talking about, and determine whether or not you're going to follow that advice. So I had to do a little soul searching after that.
Something in that picture paints that story for me on the move from psychiatry and into these various leadership roles and various positions. And when I think about someone who is walking and calmly taking in all this information, that's so that they can generate that greatest impact for a large number of people. So I know it was painful, but there's something to respect in that. And I'm curious about that migration from psychiatry and into leadership and the motivations behind that.
Yeah, I think, when I started my psychiatry residency, you couldn't possibly have convinced me that at some point I would want to be an administrator. Like many other med students, residents, you think to yourself, that's not what doctors do. Doctors take care of patients. I didn't want to be, within residency programs, either in the last year or as an additional year, they have what's called a chief resident. Chief resident does a lot of administrative tasks. They learn how to do administrative medicine. I had no interest in doing that when I was a resident at Henry Ford. So as I finished residency and kind of went into practice for the same department, I stayed with Henry Ford, and did mostly inpatient work because those were the patients that I most enjoyed taking care of. The opportunity came up where the medical director for the facility, left, and it was still fairly early in my career, and I did not think initially that I should apply for the position, but a couple of people who were already in some leadership roles, they were like, Taft, you should apply for this. And I thought about it and I said, well, how many times am I going to get an opportunity like this? Let me just throw my hat in the ring. Let me apply for it, and we'll see what happens. Well, I did well in the interviews, and probably a little bit too, it was a little early in my career. So they gave me a chance that I think they didn't have to give me. And so I came into first medical leadership at this facility. So I was the medical director for Kingswood Hospital, part of Henry Ford Health System. And it was a place where I did a lot of my residency rotations. And so the staff working there, I think that they had a vested interest in making sure that I was also successful, so I wasn't like an outsider coming in. It's a place where, I think I had a lot of folks who I'll describe as, like they would be my aunties and uncles, while they saw me as like the kid who's the doctor. And so they really wanted me to do well in this position. I think that, that helped me to learn how to get people to a consensus of what needs to happen. It helped me to learn to collaborate across different teams. So like if you're a medical leader in a hospital, you got to work with nurses, you got to work with business people who have no medical training, and you got to get everybody kind of moving in the same direction, especially on things that are clinically important to do the right way. And because these folks wanted to see me be successful, I think it was maybe a little bit easier for me to get, folks to kind of say like, look, Dr. Parsons says this is the thing that we need to do, so let's figure out how we're going to do it. Very good experience. I went from taking care of one patient at a time to being responsible for how the facility runs for, 80 to 100 patients at a time, which is it's a different perspective to say, okay, this program that we're designing in boring meetings, we're going to roll out, and it's going to affect 80 to 100 people who are there for 5 to 7 days. And so you rotate that 80 to 100 people every week or so through an entire year. That's how many people this program really affects. And if you create good, high quality programs, that's how many people's lives you improve by giving them good, evidence-based, effective care while they're there in your facility. And so it's a different perspective than taking care of one person at a time. But I think that an appreciation for how you could affect a lot of people through those boring meetings, that gave me an appreciation for what administrative medicine could be. And that kind of set me on this path to say, yes, I can be a pencil-pushing administrator for the rest of my life, because look at, the wide-ranging impact that these policies and these programs have on a lot of people's lives.
Impact is such a strong word with me, especially when I think a lot of the fear that comes from moving from clinician into administration is you don't get the visibility of that impact like immediately. So it makes me curious in this in leadership positions and things like that. What would be the accomplishment that when you think about the impact that you had? What's the accomplishment that you're most proud of as a healthcare leader?
Yeah, and I think on some level, there's nothing like the reinforcement that you get from like an individual patient that you treat, although I don't think that that's like the biggest thing that I've done. So let me give a small example. So I was at a holiday party at the Detroit Golf Club one day. And one of my friends who was there, he said, hey, I got to introduce you to this other guy. And so, he introduces me to this gentleman. And the guy goes, you're Dr. Parsons. You're Dr. Parsons. And he says, you saved my daughter's life. And so then he starts to tell me the whole story about how his daughter, a couple of years earlier, had been admitted to Kingswood Hospital. And the conversation that I had with him and his spouse at the time about, about, what it means to have a young adult child having their first break of a major mental illness and what needs to happen and what they need to do. And, this isn't something that up until that moment I had thought of as anything other than me just doing the day's work.
Mm-hmm.
But to have somebody come back and talk about how big of a difference that made in their life, it really hits home. So there's that kind of individual thing. And I mean, there's nothing more reinforcing than that. And so I think that is why a lot of people who go into healthcare, they like that individual one-on-one, I'm taking care of a patient sort of interaction. I think it helps clinicians, doctors, nurses tolerate a lot of a bad work environment because you do get that reinforcement from the people who really benefit and appreciate the care that they get. That said, I have come to these insurance companies and, created programs that affect millions of members, and so we come up with initiatives like we've had a suicide prevention and reduction initiative at CVS going for the last few years. Actually started before I came. And so we've been tracking these multiple things that we do for the membership, who have had either a suicide attempt or found to be at high risk for suicide in these reach outs that we do, screenings that we do. And we're having good results with showing that, we're reducing across millions of people the incidence of suicide and suicide attempts. Now, you have to be able to appreciate in a more abstract sense how that's benefiting people, because there's not that kind of individual one-to-one connection that you'll make with somebody saying, you, Dr. Parsons, saved my life or saved my child's life. And so it's a different way to appreciate the work that you do. And I think not everybody gets that, but I do, and so I do get fulfillment from these larger programs. But I understand and I see with examples like, that small one, there's nothing like getting that reinforcement of some real big difference that you made in one or two people's lives.
That leads me to a question that I got. I stalked you a little bit before this. I was out there at the behavioral health tech. They had a pickleball game set up, and I was out there doing interviews, and I ran into Dr. Io Gathing over at, she's a regional vice president and chief medical officer at Humana. And she mentioned that we had some overlap, and I said, hey, so Io, if you're watching this, you got to come on the podcast next. So that's an obligation now. But one question that she had, and it's really tightly tied with what you were talking about as far as the personal motivation and what you get back from hearing from individual patients. So what, behind these programs that impact millions of people, she asked me to ask you, what's the why behind your leadership and innovation?
All right. So, we talked about it before we started recording. So I'm going to just cheerlead for Dr. Gathing for a minute, because Io is one of my favorite people that I've worked with. Io is one of my favorite people, and I will say that everybody that I introduce her to, they love her, and they see that passion and that fire in her that I also see.
The things that you just said about her, they resonate. It was amazing the amount of energy that she had. She was I can't. If you like what you heard and you want to jump on with us, we're looking forward to it.
All right. Well, she does like to. We joke that she likes to follow me around. So she will be on the podcast. I'm gonna, make that pledge. So now she's obligated.
Awesome.
So like, what's the why for what I do? And I think, it goes along with kind of being able to appreciate that more kind of abstract improvement that you can bring to healthcare. Within the behavioral health space, there's a very traditional sense that every treatment, every case is very individualistic. And, when I started in residency, there was kind of a movement to bring psychiatry back to the rest of medicine. And so the challenge is that, while things like cardiology and nephrology had, kind of years and years of experience developing, these pretty sophisticated outcome measures of like, what does good look like in these other specialties, that didn't really exist in psychiatry because everything had been kind of this, very special relationship, confidential. You have the therapist or psychiatrist and the patient, and what goes on between those two is very difficult to measure. And so we didn't and don't have a lot of fantastic measures of like, what does good quality behavioral health practice look like? What does good quality treatment look like? But, we have this responsibility, this broad responsibility to take care of a population of people. And so in order to do that from a behavioral health perspective, we have to know first off, what does good look like? And second off, how do we know that people are getting that good treatment? And so as I've moved into this health plan, population health, from a behavioral health perspective, roles that I've had over the last several years, really trying to figure out how do we ensure that the members of our health plans are getting good evidence-based and effective care, and how can we demonstrate that, and how can we demonstrate improved health outcomes. That's what drives me in these sorts of roles, because there's much work to be done, but it's good work. It's good, worthwhile work. So people propose these very simplistic solutions to, how do you get good out of healthcare and health plans? And, healthcare in the U.S. is this system that has developed over many decades. And so the task is, how do we make it better? How do I do better this year than we did last year? How did we do better last year than we did the year before? And there's a ton of work to be done there. And I get satisfaction from making it better this year and next year compared to last year and the year before.
So you pose a very difficult question, which is in this mental health space and in a space where we're looking at populations. I'm going to ask you, what does good look like? And maybe you can think about how other people can ask themselves the same questions.
Okay. So, and I will say, if you think about crawl, walk, run as like this kind of progression of getting better at something, behavioral health, when we look at, how do we judge good, is probably still in the crawl phase, So we've gotten to the point, I think, as an industry within healthcare, to where people say, hey, you got to measure what you're doing in order to be able to show that good things are happening. So we have patient-reported outcome measures like PHQ-9, GAD-7. There's a bunch of them. They go into specialty conditions. And so it's the responses by a person on those scales are somewhat subjective, but you amass enough of them over time, over a huge population, they become objective. So for one person, how they're doing that day on a PHQ-9, it's their subjective report of how they feel. But you take 30 million of those, and it becomes very repeatable. It becomes statistically valid. And so it becomes a very objective measure of either improving or worsening of depression symptoms, okay? Measuring things is necessary in good evidence-based care, but it is not the same as good evidence-based care. So, we have standards that are put out by our respective professional organizations of like what should happen in depression treatment. Part of it is measuring how people are doing periodically over time, but that's not the only thing. If you're a psychiatrist, there's recommendations about medications. If you're a therapist, there's recommendations about therapeutic techniques. And what we don't have is a good way to demonstrate that those things are happening, behind that closed office door or virtual office door. So there are limitations to the large data set that we get. More recently, because of electronic medical records and some of the capabilities that they've developed to kind of send data back and forth, some companies are giving us information like, hey, for your members, this is how much better the PHQ-9s get once people get in treatment. So that is a measure of improvement once somebody's in treatment. Still doesn't necessarily mean that they got evidence-based techniques. It means that they got better. So you kind of say, well, they probably got better because they got evidence-based treatment, but it's not definite, and so you can see that we're getting better at getting closer to, being able to tell, are the clinicians actually doing those things that we know are effective treatments, but we're not quite there yet in the same way that they are in some other specialties. Because we know when people actually get better, they have improved health outcomes, not just on the behavioral health side of things, but also on the physical health side of things. So diabetics that have depression, when that depression gets treated well, their diabetes gets managed better. Their diabetes outcomes are better. And so that's where we're really trying to get to at a large scale. And like I said, if it was easy, we would already be doing it. There are different challenges when you talk about a big company, like the group of folks that are what we call aggregators. They aggregate a lot of providers underneath a corporate umbrella and do some of the office functions for them. What they can do is very different than, a therapist or a psychiatrist that is a sole practitioner, just seeing a caseload of patients who may not even at this point have an electronic medical record. So the capabilities are going to be very different, when you're talking about these big companies versus, what still makes up a large part of our network of providers is people that are in very small offices with not a lot of sophisticated EMR capability.
Well, I got to say, whenever I was fiddling with the cameras a little bit earlier, you said, don't let perfect be the enemy of done. And that, honestly, it resonates because, if you look at my LinkedIn, I am critical of PHQ-9 and various measures because of the simplicity. But with those being the best data available in a lot of scenarios, that's just what we have to work with.
Yeah. So there's kind of saying, well, that may not be the perfect thing for this person's type of depression, but because it's almost ubiquitous and everybody uses it, we have a lot of information to judge it against. And so therefore, it might not be perfect, but it's good enough for us to really get much better information if that's what we use.
Another thing I wanted to get into was, we're talking about the way people use these measurements, or the way people even perceive the difference between, the way people perceive the difference between and line between physical and mental health. And I got another question ahead of this interview about what are the sacred cows in the industry that you see as probably at risk for changing over the next 3, 4, 5 years?
I think in behavioral health, one of the things that is, I'll say a cultural thing within behavioral health is the privacy between that clinician and the patient. And it has traditionally been treated like something that's more private than what would occur between like a primary care physician and the patient. And there are situations in which either by regulation or by professional practice, some things are still treated as, quote unquote, more private than kind of a usual healthcare discussion. I think that there are situations in which that actually is detrimental to healthcare. So a lot of times the example that I'll give is, and I'll give two. One is, if you have a psychiatrist treating somebody for, let's say, bipolar disorder, common medication to prescribe would be a mood stabilizer like lithium. lithium can have effects on the kidney and thyroid. Now, if that patient says to their psychiatrist, I don't want you to tell my primary care provider about this, that PCP may not know that the high blood pressure medication that they're prescribing that works through the kidneys may interact with the lithium and actually cause kidney damage and change the levels of the lithium that the person is on. And so this is an example of something where, yes, the behavioral health care is with the behavioral health specialist, the PCP is managing the physical health conditions, but it's the same body. That patient, that individual is the same person who's taking in both medications. And so it is very important for the PCP to know about that treatment. Another situation is one where there is currently regulation that prevents some discussions, and that's around around substance use disorders. There's a federal rule that does say they are more private than kind of the usual HIPAA protected conversations that all healthcare providers and their patients have. And so if you think about a substance use disorder, and we'll take alcohol use disorder, it has multiple effects on many organ systems within the body. It increases the risk of multiple types of cancer, has effects on the liver, and so it is part and parcel to that PCP's understanding of how to manage their patient to know that that patient has an alcohol use disorder. But there are limitations to the alcohol use disorder treatment team, the people treating that condition, communicating back with the PCP, particularly if that patient does not want that communication to happen. And it's detrimental to the overall health outcome. So I think that there are these kind of privacy issues that have existed for a long time in behavioral health that are detrimental actually to the overall health outcomes. And it's, it's becoming a bit less of a sacred cow. People are kind of starting to realize that, yes, that same individual with a mental health condition and a physical health condition, those clinicians need to be able to talk to each other.
So a lot of the conversation happened around interoperability is around breaking down silos, technologically established, but this one sounds like there's
a cultural
element. Yeah.
But it does expand into the technological side because you have a lot of firewalls that are created to protect those limitations. And so, this is something that I've had to deal with, at Henry Ford, at Molina, at Humana, and now at CVS Aetna, is figuring out, where do you have a firewall that by regulation still really needs to exist? And where do you have firewalls that exist because of historical practices? And it can be a limitation to kind of the way that information flows back and forth, even within a common electronic medical record.
I love having conversations, honestly. I hope that the guests and fans get that, is love talking about the barriers that need to come down and ideas that need to change. But you've been bringing up some excellent points about the need to focus on like quality as part of that value equation. And it just makes me wonder, what would you say is missing? What nuance it might be missing from the overall conversations happening about value-based care?
I think that well, first off, yes, it's been a recent soapbox of mine because for whatever reason, value-based care has become like the it thing in behavioral health. The question is, what do you mean by value-based care? What folks mean on the primary care side can be very different than what folks mean on the behavioral health side. The capabilities and what goes into a value-based care contract on the physical health side is going to be very different than what can possibly even go into it on the behavioral health side. there are multiple different levels and types of value-based care. So at its most basic, we have things that there's several terms for it, but like pay for click, or did you do a thing? So we as the insurance plan may say, well, we value screening for depression in all of our membership. So if you screen for depression and tell us that you do it in your claim, we'll pay you a little bit extra money. That may be that's a did you do a thing sort of value-based care. Mm-hmm. The next level is like, we have these standard sets of measures like HEDIS measures, STAR measures for Medicare. And if you do well on these quality measures, we will pay you an extra amount of money. So, pay for quality bonus. Taking then upside risk. So if you manage your population of patients that, have our health plans, and you take care of them at a cost that's less than what we would otherwise pay, like compared to the rest of our network, and hit these, some of these quality measures, we'll share that savings. So it's taking upside risk. I think that, what value-based care looks like in the behavioral health space is more on that either pay for did you do a thing that we value as a company, or pay for quality scores. I think those are things where the size of a behavioral health company kind of, is appropriate to do that. Taking that shared savings and that, upside and down, so full capitation. I don't think that I've seen behavioral health companies that are large enough to do that. And it becomes a problem of how do you attribute the savings to the behavioral health intervention? So oftentimes, that member will have a value-based contract with the PCP practice that they're in, and so the PCP practice, is going to want to make sure that they get all the credit that they deserve. And if you take that earlier example of somebody that's got depression and diabetes, right? And the diabetes gets managed better, how much credit do you give the behavioral health team? Which is a difficult thing to do, because there's not like a universal consensus on how big of an influence behavioral health management has on the outcomes with physical health conditions.
In our conversation, we started from your personal journey. Mm-hmm. And, we started from the time before you were in healthcare and healthcare administration. Yeah. And like with the kinds of changes that you see and the difference that you're making at that executive level, it always makes me reflect back. Even like in my role in data science, my mom asked me, what am I learning about the stuff that we're analyzing at Wobot? And there actually has been some benefit back to her and back to my family just by working in data science in this field. And it just makes me wonder your message for people outside of healthcare that are trying to navigate this complex system. What's your message for how people can overcome a lot of the barriers and difficulties that they're going to face in their healthcare journeys?
Well, I think it's all right. There's not a simple answer to that. I think if you're talking about somebody who is simply functioning as a patient, getting health care, you need to be connected to a primary care provider and a primary care team. They are the quarterbacks. They are the ones who are there to help navigate some of the complexity within the healthcare system. And if you're not engaging with a primary care provider, you will be at a detriment when you actually need health care for a specific condition or in an emergency. So just as a general patient, if you don't have a primary care provider, you need to get one. Those are the people that are the quarterbacks of healthcare. They are the ones that help their teams, their staff, help navigate some of these challenges, like things like insurance approvals, things like how do you schedule multiple tests on a given day? Do you need to see a specialist, or is this something that the PCP can handle? So those things, they are there in part to make sure that the healthcare that you get is as efficient as it can be, and to help you navigate that.
Well, this forces our next question, because like we're talking about agreement and all these workarounds and everything like that, but we're going to give you a special power that will let you do anything that you want.
Now,
You could change any one thing about healthcare. So yeah, you only get one thing, but what would that one thing that you would change be?
the one thing that I would change is, I think, and you see it here compared to other countries, is that we kind of put healthcare and what we count as healthcare into a box. But we know that some of the things that affect people's health the most are things that are not quote unquote traditional healthcare. So the ability to figure out how to pull in things like what we call social determinants of health, nutrition, exercise, pulling those things into the larger umbrella of actual healthcare, so that, when a doctor has a patient who has unstable housing, that there is actually a resource to easily point them to get that problem solved. That's going to improve their health way more than any particular medication that a doctor can prescribe. And so our system is really not set up to address the things that actually, in a very practical sense, affect your health more so than, did you get the right diagnosis? Did you get prescribed the right medication? And if I could wave a magic wand, it would be to pull those things in and to kind of create that infrastructure at a large scale to deal with that.
Tactical question. Let's say the infrastructure is there and the data are there, and there is a way to know, like it exists in the system somewhere, that this person has the inability to pay their power bill the next month, but there's resources available. How do you let the doctor know in that scenario so that they can act on it?
Oh, in that scenario, the doctor wouldn't need to know, because somebody either within that office or within kind of like the larger, maybe at a health plan, would already know about that and would be reaching out and say, hey, we see that the last 4 months you only paid part of your power bill, and we see that you may be having some, winter is coming, and we see that it might be hard for you to keep the power. I'm sure that's stressing you out. We have this program where we can make sure that you have your heat and lights on. Now, right now, programs like that exist, but they're not easy to get to. They're not easy to connect the people that need it to the actual resource. And a lot of times there's just not enough of it either, So yes, like programs to provide housing exist, but they tend to be very small. They tend to be very local. They tend to be hard to get into, and so because of that, a large segment of folks that are in that dire need suffer quite a bit. And when you don't know where you're going to sleep the next day or the next week, you're not worrying about picking up your script from CVS. And so we already know that, like, these health outcomes with all these issues that people face in their day-to-day lives affects their health outcome way more than whether or not they saw the doctor and the doctor made the right diagnosis and gave the right prescription. So
it's extremely hard, but I think it's I believe in the art of the possible on that one. And even if you can't do it with a magic wand, it's a fight worth fighting for.
Yeah.
With that, Taft, I know like people, they listen to you, and I'm curious about, like, anybody who watched this interview and wants to keep up or understand what you're doing, what your moves are, and what you're thinking about. What's a good way for them to follow you on social?
Probably the only social that I actually have is LinkedIn. So, that is where I post stuff relevant to the discussion that we've had today, including sometimes personal anecdotes and things that have popped up. If I see that it is useful in kind of forwarding some, kind of healthcare related thing that I'm working on. So that's the place to find me.
Well, I appreciate that. And honestly, I appreciate what you share on LinkedIn because there's like, I took this as an opportunity to dig deep on a lot of the nuance that I've seen you share. And that's what makes me happy about this conversation is the fact that we can dig in deep on nuance, and it's happening at least once a week, at least a couple of times a week on LinkedIn. All right, with that, well, thank you very much, everybody, for sticking around with us for this conversation. Hope you got a lot of value out of it, but also a lot of power and thought that you can start taking into your own roles. With that, thank you very much.
All right, thank you. It's been a pleasure.